Hello everyone, welcome to your GI Module 1 lecture. We will talk about upper GI complications. This module covers chapters 45 and 46 in your textbook. The disorders we're going to cover are gastroesophageal reflux disease, commonly known as GERD. We'll talk about hiatal hernias and how they are associated with GERD. We will look at different types of upper GI bleeding and what disorders are related to or cause the upper GI bleeding. We'll look at peptic ulcer diseases and the types of ulcers included in this disease. And we will also look at H. pylori bacteria and how it plays a role in the development of peptic ulcer disease. We will also look at some upper GI pharmacology and round out the lecture with gastric cancers. Starting off with GERD, or gastroesophageal reflux disease. So this is probably one of the most common disorders that we are going to see as a co-occurring disorder in a lot of the clients that we treat in the hospital. When we're taking medical history, it seems like a majority of our clients will have some form of GERD in their history, along with maybe some asthma or COPD, maybe some hypertension. If they have obesity, maybe they smoke or are pregnant, they might also have GERD as part of their medical history. Let's look at some causes of GERD. A hiatal hernia can cause GERD, and that is where there's a little bit of basically outpouching of the stomach up through the diaphragm, and we'll cover those a little bit later in the lecture. One of the biggest reasons that we see GERD occur in our clients is a lower esophageal sphincter that has become incompetent. So it's lost its ability to close all the way. It maybe doesn't close as fast as it should. Something has happened with that LES that has allowed more gastric contents, or any gastric contents for that matter, to back up into the esophagus. We can also have some decreased esophageal clearance, meaning food product that goes through the esophagus doesn't completely empty out into the stomach. And then we can also have some decreased gastric emptying, meaning contents that are in the stomach are not emptying out from the stomach entirely. Risk factors that put you at an increased risk for developing GERD are obesity, smoking, pregnancy, more related to the increased space that the uterus is taking up. As the uterus grows, it starts to push up on all of the other organs. Less amount of room for the stomach to occupy. So if they're eating the same amount, there's less room for the food to go, and that can back up into the esophagus, causing GERD. There are some foods and medications specifically that can impact the LES. Anything that contains caffeine can affect the competence of the LES, and then anticholinergic medications can also play a role. Looking at clinical manifestations of GERD, one of the biggest complaints that a client is going to have is heartburn or pyrosis. Other one is going to be dyspepsia. They'll have some hypersalivation. Regurgitation is common. When we talk about non-cardiac chest pain, these are especially going to be found in our elderly clients, or maybe 40s, 50s, 60-year-old clients. When we talk about non-cardiac chest pain, a lot of the times when these clients come in complaining of burning in their chest, that burning sensation truly is related to GERD, but because of their age and medical history, we're probably going to run down the cardiac workup route to rule out an MI or rule out the more serious complication that could be occurring. When we draw labs and do all the things associated with diagnostics of a myocardial infarction, we're going to realize that they have normal troponin levels, probably normal blood pressures, normal vital signs and everything, so that they're really not going to be having that cardiac related chest pain. But they could be diaphoretic. They could have a lot of similar symptoms. Most of the times, clients with GERD are going to have mild symptoms. They'll happen, a couple times a week, nothing significant. And the exacerbations of this are not going to be severe enough that they're going to cause mucosal damage to the esophagus. So there's no evidence really that they have GERD, just that their symptoms kind of fit into this diagnosis. And they'll try, maybe some over-the-counter medications first. They'll start taking Tums on a regular basis, and they could possibly manage the symptoms outpatient. And if they have progression of the disease or the over-the-counter medications aren't working anymore, they choose to go see a doctor. They might end up with the official diagnosis of GERD just out of the symptoms they've been experiencing and the length of time they've been experiencing them. Really, to get a diagnosis of GERD, you're going to have these episodes more than twice per week. You could also see some respiratory associated symptoms just because the esophagus having that burning sensation, having the lump in the throat, feeling like you can't fully swallow a piece of food, feeling like it's stuck there. There could be some sore throat, hoarseness, shortness of breath, coughing. Those would be less common, but you may see them as a manifestation for these patients. For complications associated with GERD, the complications are going to be dependent on the length of time that the patient has had GERD and how well they are controlling the GERD. So are they following a less offensive diet? Are they following their medication regimen? If they are, their complications will be minimized. If they aren't, or it's gone undiagnosed for an extended period of time, then they're going to have some of these complications. So one of the bigger ones that they'll see is esophagitis, which is just inflammation of the esophagus. And as the acidic contents are kind of wearing away at the tissue, inflammatory response is triggered. If the acid is present in excessive amounts, the longer the tissue is exposed to acid, it'll start eating away at the tissue and you'll have the ulcerations. That's where the pain will become much more severe. There could also be strictures in relationship to the swelling, just essentially a narrowing of the esophagus. When we talk about Barrett esophagus, this is a condition where the esophageal lining, or the mucosa that lines the esophagus, has become altered. And it essentially, the cells of the lining change, and it can be associated with a precancerous type situation, but it will definitely increase the patient's or client's risk for developing cancer at a later time. African Americans and Asian Americans are least likely to see this. This will be more common in your white men who are older in age. So not quite like geriatric population, but we're talking maybe around 50 years, 40 to 50 years old. When we look at diagnostic studies for GERD, a lot of times we can diagnose this just off of the health history and the symptoms they've been experiencing and the length of time that they've been experiencing the symptoms. But a definitive diagnosis can be an endoscopy, where the camera goes down, goes through the mouth and into the stomach. As it passes through the esophagus, they can assess any damage present in the esophagus, and then look inside the stomach. Is there delayed gastric emptying? They can do some barium swallows that really light up the entire GI tract and will highlight any abnormalities that are present. Clinical management for GERD. So this is really going to focus on lifestyle modification and nutrition education, alongside with medication regimen. So when we are managing these patients, we want to pay close attention to what they are eating and when they're eating it. If obesity is a component of their diagnosis, then obviously promoting weight loss is going to be important. Smoking cessation as well. pretty much anything that any patient who is smoking really should stop, because we now know that smoking is tied to so many comorbidities, so many diagnoses. When we're talking about nutrition, there are certain foods that we know are going to exacerbate episodes, and certain foods that really are the safe foods. So if your client really likes to go out for super spicy Mexican food, they need to understand that by doing that, they are most likely going to have an exacerbation of their symptoms. You want to avoid some acidic foods because the stomach contents are already acidic enough. If we are adding acidic foods to that, it's only going to exacerbate the amount of acid and damage that that acid can cause to the esophageal lining and the stomach lining. Smaller, frequent meals are going to be much better than eating a large filling meal. Remember, we talked about the decreased gastric emptying being a component of this disease process. So if we're eating smaller meals, we're kind of keeping that metabolism going. Our stomach is used to smaller amounts of food and processing it quicker, getting it out of the stomach. Chewing gum or having the throat lozenges or like peppermint candies, things like that, those can help keep gastric motility going without actually eating food. So those are going to be modifications that we can teach our patients. We can also talk about medication management. Some of the bigger medications, or really maybe first line medications that are going to be tried, are your H2 blockers and your proton pump inhibitors. So the H2 blockers like Pepcid, Zantac, Tagamet, and then our over-the-counter proton pump inhibitors like Prilosec, Nexium, Prevacid, things like that. Those are both going to be your medications that are focusing, or medication classes that are focusing on decreasing acid production. So there's different ways that we can look at medicating. If they are producing too much, then we want to decrease gastric acid production. We can also neutralize acid production. That's going to be our Tums or the Maalox medications like that. Those are your true antacid medications that just neutralize what is present in the stomach. We might try some Reglan, that's the metoclopramide. That's a prokinetic medication that is focused on accelerating gastric emptying. And we'll see Reglan used kind of across the board. It's a newer medication that is being used in nausea medication just because it helps with that gastric emptying. One of the big side effects with Reglan is it can cause tardive dyskinesia. So if you give this medication to a client, that if they could have that reaction, and it's not technically a allergy to the medication, but it would be a reason to not continue that kind of a treatment. We can also look at surface agent protection, which is our cytoprotective agents or sulcrafate. These medications really just provide a barrier, kind of coat the lining of the stomach. If medication management is not working, then we can look at surgical routes. We could try endoscopies if we're worried about, cell change, if we're worried about maybe a Barrett esophagus and we want to do a biopsy of some of the tissue. We can look at doing an endoscopy and really assessing the mucosal lining. And if possibly it is a significant issue of the lower sphincter or the lower esophageal sphincter, then we can look at a Nissen or Trappe surgery, which is where they are targeting support for the lower esophageal sphincter. They can even use magnets, where they would put magnets around the lower esophageal sphincter that provides strength and better ability for it to close and remain closed, to prevent that gastric contents for backing up into the esophagus. Nursing management for these patients, again, it goes back to teaching, client teaching. We are covering their diet. We're really supporting and encouraging smoking cessation. We really need them to follow the medication regimen. If they are not taking these medications that they are prescribed on a regular basis, then their symptoms are not going to be well controlled. In the hospital, we can keep their head of bed elevated at least 30 degrees or higher. Gravity is our friend. If we can keep the gastric contents in the stomach and help prevent them from backing up into the esophagus, then we can help minimize their symptoms. We want to make sure they understand that sitting up for at least 2 to 3 hours after eating, or even standing up and walking around for a while after eating, can help with gastric emptying and help keep um, food and acid contents from backing up into the esophagus. It is really a bad idea for these clients to lay flat after eating because it's just going to perpetuate the availability for food to back up into the esophagus. We really want to advise them to avoid any foods or medications that can increase their symptoms. If there are any medications that they are prescribed that have some significant side effects, we're going to want to discuss those. If they are going for any surgical intervention, then you would add some post-op teaching into the client teaching. And then, bottom line, this is a recurring disorder and management is going to be key, but most patients will have a recurrence of this disease process over the course of their lifetime. All right, let's move on to hiatal hernias and how these will impact a client dealing with not only GERD, but if we happen to find a hiatal hernia on their chest x-ray. So hiatal hernias really are an opening through the diaphragm where part of the esophagus pushes through. So there's two types of hiatal hernias that we will see. The first type, which is the one that is depicted by A in the image on the screen, this is a sliding esophageal hernia. So the lowest portion of the esophagus really kind of slides up into the diaphragm, and it can slide in and out of the diaphragm. So you'll have that outpouching. It won't necessarily stay out, but it's known as a sliding esophageal hernia. Essentially, the upper stomach and the esophageal junction have moved upward, and they will slide in and out of the thorax. The second one that we will see, the one that's depicted by the B image on the screen, this is a paraesophageal hernia where all or part of the stomach will push through the diaphragm next to that gastroesophageal junction. So you can see the two pictures are different. The gastroesophageal junction is really, let me highlight it here for you. So that's the gastroesophageal junction where the esophagus connects into the stomach. So in the paraesophageal hernia, that junction is intact, but the outpouching happens right next to it. In the sliding esophageal hernia, this part of the stomach is intact. The gastroesophageal junction is right here, and it's really that upper part that slides in and out of the thorax. Symptoms with hiatal hernia will kind of mimic GERD, so we need to make sure that we are differentiating between the two. You can have some heartburn, some regurgitation, and dysphagia associated with hiatal hernias. How do we diagnose a hiatal hernia? Hiatal hernias really are probably one of the most common incidental findings that you will see on a chest x-ray. For example, you have a patient coming into the hospital who is complaining of some sort of respiratory component. Maybe they have, pneumonia, bronchitis, asthma, something like that. And the ER physician decides to do a chest x-ray just to check the status of the lungs and see if there's any infiltrates. The bottom of a chest x-ray more often than not will include the very top of the stomach, and it'll catch that gastroesophageal junction and the lower part of the diaphragm. So if there is a hiatal hernia, we know that these types of hernias will poke up into the diaphragm. It'll break that diaphragmatic lining. So while they may not have pneumonia, hey, guess what? Did you know that you have a hiatal hernia? So it is probably the most common incidental finding on an x-ray. They can also do a barium swallow. Again, when you do the barium swallow, it's that the radiation pretty much highlights any abnormalities in the GI tract. And we can also do the EGD where the camera goes in and we can get picture evidence of anything going on in the esophagus and in the stomach. When we manage these types of hernias, it's very similar to our GERD management. Small, frequent meals. We don't want them to lay down for at least an hour to 2 hours after eating. You can even, raise the head of the bed on blocks if they're not able to sit up entirely, depending on what their comorbidities are. And then if symptoms are pretty severe, then surgery is an option. Surgery is more reserved for the management of GERD if the medication management has failed. But if the symptoms, again, if they're severe enough with hiatal hernias, then we can do surgical repair of the hernia. Moving on to upper GI bleeds. We're looking at about 250,000 people in the US annually are going to experience GI bleeding. A lot of them are going to be your elderly client population. We can have a sudden onset of GI bleeding, or it can be kind of more of a vague onset. There's different types of bleeding. It can be venous, arterial, or capillary. So I want you to think about the different types of bleeding and what you think that blood is going to look like. So if we have a venous bleed, we know that it's going to be a slower bleed. Capillary bleeds are also going to be slow. They're going to be much slower than a venous bleed, a much smaller amount as well. Your arterial bleed is going to be very powerful. It's going to be a lot of blood. And those are going to be the types of bleeding that can jeopardize the patient's life. So those are medical emergencies if we determine that the patient has an arterial bleed somewhere. When we have a venous or a capillary bleed, these can go unnoticed for, periods of time. The biggest complication or biggest clinical manifestation that we'll see with a GI bleed is hematemesis. The stomach does not digest blood. It stays there. So some of it is going to make it into the intestines, but a lot of it is going to be vomited out. So hema meaning blood and emesis meaning vomit. The blood that does make it out of the stomach and into the intestines is going to come out as melena or blood in the stool. We could have some occult bleeding where, we would do the testing and we would find the blood in the stool. When we're looking at esophageal bleeding specifically, this is going to be your patients who have had the chronic esophagitis. So they've had GERD that's maybe been mismanaged for a really long time. That's caused some ulcerations, and those ulcerations are now bleeding. Could be arterial, could be venous, but your venous bleeding is going to be more common in GERD-related bleeding. Drug ingestions can cause it. Alcohol and cigarettes can cause it as well. When we look at a Mallory-Weiss tear, we're talking about a tear in the esophagus that is near that esophageal gastric junction. Esophageal varices, however, are going to be probably the most significant medical emergency that we're going to see with upper GI bleeding. These a varice or esophageal varice is kind of like a hemorrhoid or a dilated vein that is inside the esophagus, and when it pops, it bleeds a lot. We have respiratory compromise, we have hemorrhaging, we have hemodynamic instability that we're significantly at risk for here. So esophageal varices are a medical emergency and require immediate intervention. Stomach and duodenal bleeding, these are going to be your peptic ulcers that have gotten severe enough that they are starting to bleed. Certain medications also can cause bleeding in the stomach. We know that if a patient or a client is on aspirin therapy for extended periods of time, that they are at higher risk for bleeding from the GI tract. Stress-related mucosal disease like stress, physiological stress ulcers, if there's maybe some trauma or burns. These ulcers that are present can be diffuse, they can be superficial, significant in implications or minor, but they can still cause bleeding. About 40% of the cases that we see for GI bleeding are going to be due to peptic ulcers. As far as drugs or medications that are causing bleeding, your NSAIDs, your aspirin, things like that are going to be your biggest medication cause for GI bleeds. And that's maybe like about 25 or so % of our GI bleeds. So what are we doing as far as management if we have a client who has been diagnosed with an upper GI bleed? Hopefully the hemorrhage stops on its own. If it's esophageal varices, they probably are not going to stop, and we're going to have to go in and cauterize those bleeding vessels. We need to identify and treat the cause of the bleeding, physical assessments. We're going to monitor vital signs rather frequently because we're looking for, drop in blood pressure. They're probably going to be tachycardic as they are trying to compensate. We're going to assess the abdomen. Why would an abdomen be rigid? If they are bleeding a lot, if they're hemorrhaging into their stomach, the abdomen is going to become rigid. We're going to draw initial labs and then serial labs to monitor interventions and whatnot. We're going to get some large bore IV or large gauge needles. Probably 2 lines in these patients. We're probably going to be running fluids and blood simultaneously, depending on the severity of the bleed. Blood product administration, if it's an emergent intervention, we're looking at simple O-negative infusions. If we have the time to effectively cross-match the patient, then they can get blood that is specific to their blood type. We're going to want to put in an indwelling urinary catheter because our, kind of a gold standard sign in fluid and hemodynamic stability is that they are outputting adequate amounts of urine. And if we have that catheter in place, then we can get specific hourly counts or exact hourly urine output counts. Patients with GI bleeds are also going to get a proton pump inhibitor therapy. This is going to be our Protonix in the hospital. So they will get, you guys are probably used to by now seeing Protonix as a tablet given to some of your patients on the med-surg floors. When we're looking at emergent management for upper GI bleeding, we're looking at getting this medication into them via IV bolus and then a maintenance IV infusion. Also, if we can't get the hemorrhage or the hemorrhaging does not stop on its own, then we're looking at an endoscopy and the need for either cauterizing the vessels or we can do specific injections or targeted injections of epinephrine. We know that epinephrine is a vasoconstrictor. So if I give that or if I inject that into a bleeding vessel, I'm going to cause it to constrict and hopefully stop bleeding. Further clinical management, we'll want to do an endoscopy within 24 hours. If they do have esophageal varices, we're going to approach that with significant caution because anything that we introduce into the esophagus could chance rupturing another varice. Possibly do a gastric lavage. Again, the stomach does not digest blood, so we may have to go in there and actually remove some of the contents that are hanging out. We can drop an NG tube in these patients and remove the blood that way. We want to make sure that they're achieving hemostasis, that we are, whether we need to cauterize the vessels or what we're looking at to get that bleeding to stop. If we can't get it to stop, then we're looking at significant surgical interventions. Any medications we can give that are going to decrease bleeding, decrease or neutralize the acid, and then again, that epinephrine injection into those ulcers or bleeding vessels. Nursing management, we're identifying any patients who are at risk for developing a GI bleed. Patient education is going to be a component of that, as well as medication teaching. We want them to stop smoking again. And if they've had an episode of GI bleeding, they're at risk for bleeding again. So teaching to help prevent further episodes. Not straining on the toilet to have a bowel movement can assist in decreasing the risk for further episodes. In the hospital, we're looking at monitoring their IV and blood product administration. We do not want them to have anything that has red dyes in it, because red is easily confused with blood, and we might think that they, started to rebleed, and really it was just the red jello that they had for lunch. So no red foods when they are inside the hospital. Elderly, we know that they're going to be at higher risk for cardiac problems. They have less compensatory reserves. So if a young, healthy male happens to have a spontaneous GI bleed, their compensatory mechanisms are going to be much stronger. Whereas if an elderly male client begins to spontaneously bleed, he will run into cardiac stressors a lot sooner in the event. Lavage with cool or iced fluid. This is less commonly used. We're trying really not to put fluid in. We want to get everything out. And then we're going to be monitoring their labs and doing some Alcott stool samples to see if they still have blood coming out in their stool. All right, if you want to pause the video, we are about 30 minutes in, so this would be a great time to take a quick break and grab a snack, maybe refill your water, and then you can restart the video when you're ready to go. All right, moving on to peptic ulcer disease. Peptic ulcer disease is pretty prevalent as well, it affecting about 4.5 million Americans annually. Usually a smaller percentage of those patients. There are three types of peptic ulcers. There are gastric ulcers and duodenal ulcers being the main two that we are going to focus on. Esophageal ulcers can also be classified as a peptic ulcer, but it would really more so depend on the location in the esophagus. So for our purposes, we are focusing on gastric and duodenal ulcers only. So what is an ulcer? It is essentially an area that has been impacted by acid to the extent that it creates a hole in the mucosa of the stomach. Basically, either in the stomach, being a gastric ulcer, or in the pylorus, which would be a duodenum, or in the duodenum. This erosion, it can extend through multiple layers. It could be fairly superficial and not be bleeding, or it can extend through the entire stomach and into the muscles surrounding the stomach. They can be acute or chronic. Acute, there's just really a superficial erosion. There's minimal inflammation associated with it. Chronic is really what chronic conditions are. It's, more exposure, longer duration, and a more significant eroding of the wall of the stomach. There also can be some scar tissue or fibrous tissue that forms around the ulcer. The development of these ulcers really happen because of a super acidic environment. So maybe antacids haven't worked, other medications haven't worked, and then it progresses into an ulceration of the stomach lining. If you want a great YouTube video on the explanation of peptic ulcer disease and everything that kind of coincides with it, type this YouTube link into another browser window and it will give you a pretty good explanation. I can't click on it in this recorded lecture because it will mess with the overall recording. But for further information, go ahead and type that link in and view that video. It really is a good one. Moving on to causes of peptic ulcer diseases. H. pylori, the Helicobacter pylori bacteria, is one of the Um, Most common reasons that a client is going to develop a peptic ulcer, about 50% of the population in the world is infected with an H. pylori, but not everyone is going to have symptoms. If we are looking at an H. pylori associated ulcer, then we're looking at some medications, some triple, they call it triple therapy, as far as the antibiotics and antacids or proton pump inhibitors or other medications that we're going to be using in the treatment of an H. pylori associated ulcer. To help minimize the ulcers or the symptoms experienced with the ulcers, we're going right back to the dietary management, lifestyle modification. So, alcohol, coffee, either hopefully eliminated altogether. There is a such thing as a stress induced ulcer. So, minimizing physiologic or psychologic, distress that can help minimize the chance of developing an ulcer. And then, if they are a current smoker, then decreasing or eliminating the smoking component is going to help. Both women and men have about an equal chance of developing these types of ulcers. They are more commonly seen in middle-aged adults, um, not necessarily are 65 and older, but they can be seen. The NSAID use can be what precipitates H. pylori infection, so be aware of that. Um, it really all has to do with the damage of the mucosal lining and how, without having that protection, the chance for an infection, the H. pylori infection, exacerbates and becomes much more prominent. Our stomach is really good at protecting against infections, and when we have the damage to that lining, it can't protect against bacteria very well. So again, the development of the H. pylori infections because of that. The stress ulcers are another reason, like that would be regardless of the amount of mucosal protectant that's there, it still just will develop based off of the stress, and that can be the physiologic or psychologic stress. If there might, maybe they have burns or they become septic or have multiple organ dysfunction, things like that, those can precipitate the development of an ulcer. Clinical manifestations, we kind of covered those already in previous, but we're going to go over them right now. So the differences between gastric and duodenal ulcers, the symptoms that they experience are going to be maybe a little bit different depending on the location of the ulcer. They possibly, if it's a pretty minor ulceration, they might not have any symptoms, or it could take, quite a while for the symptoms to get severe or the ulcer to get severe enough to start really showing those symptoms. But if we have some gastric ulcers, those are, higher up in the stomach. They could have the dyspepsia that could be happening 1 to 2 hours after meals. They could have the burning sensation, maybe a little extra gas production, so they're burping a lot. The food can aggravate the ulcer if the mucosa around it is eroded, and it's really all because this ulcer is higher in the epigastrum. Your duodenal ulcers, because those are the duodenum is that part of the bowel that's pretty much right connected to the stomach. That is when acid actually comes in contact with the ulcer. You can have burning or cramping associated with that. This is several hours after eating. So the gastric ulcers, that's when the food is still in the stomach. That's when it's going to be irritating. The duodenal ulcers will have pain, 2 to 5 hours after eating when that food is entered into the duodenum. They can have back pain and xiphoid pain, both associated with this type of ulcer, commonly confused with cardiac type chest pain as well, just given the location. Your elderly population, especially elderly women, will present with chest pain symptoms that are not typical. They could have, pain down their arm or lower back pain, and you're not really suspecting an MI, but that is what's actually occurring. So, especially with the elderly clients, we need to be really careful what we're assessing and really what we're looking for. Moving on to complications of ulcers, and this is really any ulcer, so whether it's a gastric or duodenal ulcer, your biggest complication that can be seen is hemorrhage. So they could be bleeding ulcers, and that can cause a lot of the symptoms that we discussed earlier in the lecture, talking about upper GI bleeding. If the ulceration is severe enough, it can actually cause a perforation, and this can lead to sepsis and can be lethal overall. These are going to be your larger penetrating ulcers. They'll have a sudden and dramatic onset of abdominal pain. So the stomach does a really good job at protecting what's inside of it, but once there is a hole into the rest of the abdomen, then they're going to have some pretty significant pain. As the disease process progresses and the contents kind of leak into the abdomen, you're going to, on assessment, you'll have a rigid abdomen. They could have some rapid, shallow pulse as the compensatory mechanisms take hold. And then another complication would be gastric outlet obstruction. So if we have any edema or swelling, you could have some spasms in the tissue or some fibrous scars, and that can prevent the gastric outlet from completely emptying. This can cause some projectile vomiting, so nothing is going to go down into the intestines, which can also lead to constipation and in turn dehydration, because we know that a lot of our fluid reabsorption happens down in the intestines. How do we diagnose peptic ulcer? Similar to the other things that we've talked about, endoscopy. If we need to rule out an H. pylori infection, then we're going to do the test specifically for H. pylori bacteria presence. We can do the barium swallow, and then we can do some fasting serum gastric levels, and then your standard CBC, liver enzymes, amylase, UA, and stool studies to confirm diagnosis. How do we manage it? Rest, smoking cessation. If they are taking NSAIDs, we're going to stop those, and then we want them to restrict or avoid alcohol and any medications that could be offending as well. We can give them protective medications, so the cytoprotective meds, the sulcrafate. Misoprostol is actually a medication that can be used. I know you guys talked briefly about that one in your OB content, but this medication actually can be used in treatment of some GI issues. We can also use some tricyclic antidepressants as well. They contribute to pain relief. Actually, a lot of issues with pain, depression can kind of coincide with that. So there has been some off-label use of tricyclics in pain management. And then, same as previous disorders we've discussed, your smaller, more frequent meals, avoiding caffeine, spicy foods, anything that can trigger the episodes. Specific medications that we talk about with peptic ulcer disease are going to be our H2 receptor blockers and our protein pump inhibitors. These are healing medications and are often used in combination. The severity of the peptic ulcer that is present, it might need more than one therapy in order to help manage it. Some other medications, if we are looking specifically at an H. pylori infection, we're looking at triple therapy. So that's going to be 2 antibiotic medications and 1 anti-secretory medication. So either an H2 receptor blocker or a proton pump inhibitor. There may sometimes be mention of a quadruple therapy where they would use 2 antibiotics and then both an H2 receptor and a PPI medication. It often, depending on the severity of the H. pylori infection, it can take more than 1 round of these medications, and 1 round is typically a 2-week treatment when we're talking about antibiotic therapy. We can also use antacids. We know that the acidity is what's going to exacerbate the pain with these peptic ulcers. So we can use antacids as an adjunct therapy. We can increase the gastric pH, so make it not as acidic, and then manage any side effects associated with using antacid therapy. So here is what a perforation looks like. You can see it right in the middle of this picture right here. That hole is where it is perforated through the stomach lining. These are medical emergencies. We're going to be inserting NG tubes because we want to get whatever contents are remaining in the stomach out. We're going to do some LR infusion, replacement of RBCs if needed, and then we're going to monitor the patient. Depending on the severity of the perforation, it could be repaired laparoscopically, or if we're really worried about maybe a combined peritonitis as well, they might need to be a complete open repair so that they can really get in there and assess the entire situation of the abdomen. Okay, looking specifically at gastric outlet obstructions, peptic ulcer diseases are really the leading cause for a gastric outlet obstruction. And this is essentially when the pyloric sphincter becomes scarred and like from the edema or whatever spasms are going on related to the ulcer. And when it heals, then things, don't go through the way they're supposed to. So if we're not emptying the stomach, obviously we have to get an NG tube in to decompress the stomach and get any of the contents out. We will correct any fluid imbalances related to this. And as it, heals or we move on, we can clamp the NG tube and measure residual volume before we just completely remove the tube later on. During the course of treatment, measuring residual volumes kind of come into play for a lot of different things. If you're doing tube feedings or anything like that, you can adjust your rate of tube feeding related to how much residual volume there is left. But for a gastric outlet obstruction, the way that we would diagnose that is we would clamp the NG tube, and then if there's a residual volume of more than about 400 mLs, then that would suggest that there is an obstruction. Okay, moving on to gastric cancers. This is one of the cancers that men are at greater risk for developing than women, and specifically Hispanic, Asian Pacific Islanders, or African Americans are at greater risk for gastric cancers than Caucasian. These are usually an adenocarcinoma. They can happen anywhere in the stomach, and there's often very few symptoms. Tumors, most tumors aren't palpable. You're not going to find them by your standard abdominal assessment and palpation. Certainly not going to hear a tumor when you're auscultating the abdomen. You might see some ascites or hepatomegaly if there has been metastasized of the tumor itself. EGD is going to be your standard diagnostic, so they can take some biopsies, determine if it's malignant or benign, and then surgery to remove if that is an option, chemotherapy, radiation. There also could be the need for a partial or total gastrectomy depending on the severity of the cancer and the client's response to treatment. All right, guys, that is going to wrap up our upper GI disorders. Hopefully this lecture has been helpful. If you have any questions related to content presented, either bring them to lecture with you on Thursday, or you can send me an email and I'm happy to respond and clarify that way. Or you can schedule office hours if you really just want to sit down and point out some things in your book that you're confused about or whatnot. I am happy to be here to clarify. See you guys soon.